Well, hello everyone, and thank you for joining us today. This is Jen Cooper from the Association of Public Health Nurses. Before we get started with our webinar today, I just want to go over some logistics. At the end of this webinar, there will be a question and answer session. So you're welcome to submit questions at any time using the Q&A function on your screen. That is probably at the very top or very bottom of your screen. There's also a chat function, and you're welcome to put questions in there as well. And I'll be monitoring this throughout the webinar. So again, my name's Jen Cooper with APHN, and we're a national organization that supports the role of practicing community and public health nurses. And over the last few years, APHN has worked with the Midwestern Public Health Training Center, which covers the 4 states of Iowa, Kansas, Missouri, and Nebraska, on their focus specific to diabetes prevention and management. So to that end, we wanted to bring together partners to discuss challenges and successes in this region, and specifically look at how groups and organizations around the region and country are working to develop and sustain the diabetes prevention program and also the diabetes self-management program. So today we've invited the National Council on Aging and various teams in the Commonwealth of Virginia to share about their work with these 2 programs. So I thank all of you that are on with us today and your willingness to share about your experiences and all the work that you're doing. And I'd like to turn this over now to Katie Zucke from the National Council on Aging. She's a senior program manager at the Center for Healthy Aging, which is part of the National Council on Aging. And in this role, she provides technical assistance to state and community-based organizations that are working to implement, expand, and sustain chronic disease self-management education across the country. So again, welcome to all of you, and I'll turn this over to Katie Zucke.
Thank you so much, Jen, and thank you to the Association of Public Health Nurses and the Midwestern Public Health Training Center for this great opportunity to collaborate on a webinar today. As Jen mentioned, I am from the National Council on Aging, and I am going to share a little bit about the resources that we have available to support your work in implementing, expanding, and sustaining evidence-based programs before we hear about the work of our partners in Virginia. At the National Council on Aging, our mission is to create a just and caring society where everybody has the opportunity to age with dignity, purpose, and security. I specifically work in our Center for Healthy Aging, where we have the goal of increasing the quality and years of healthy life for older adults and adults with disabilities. We operate 2 national resource centers funded by the Administration for Community Living. One is focused on chronic disease self-management education, or CDSME, and the other is focused on falls prevention. And we also do work around other healthy aging topics, including behavioral health, physical activity, vaccinations, and oral health. Through our 2 national resource centers, we provide training and technical assistance to state and local community organizations that are implementing evidence-based programs that are approved and have been established as evidence-based through the criteria set forth by the Administration for Community Living. This is a list of some of the programs, it's not exhaustive, that we support community-based organizations in implementing. And today we're going to focus specifically on programs that can be implemented with adults with diabetes or prediabetes, including the Chronic Disease Self-Management Program, or CDSMP, the Diabetes Self-Management Program, or DSMP, and the Diabetes Prevention Program, also known as DPP. State and local organizations across the country use a variety of different types of funding to support work in evidence-based programs. The Administration for Community Living has funded these programs through a variety of different mechanisms since 2003, and that continues through new grants that will begin in August of 2018. Other organizations use funding from the CDC or local, state, or private sources to support these programs. But we know overall that funding is limited and unreliable. Regardless of the source of funding that organizations are using, there's no guarantee that that funding will continue into the future. And often those grants have been established with the goal of supporting organizations in establishing the infrastructure and building the capacity to implement evidence-based programs, and also to develop a sustainable, integrated system so that this work can move forward in the future. We also know that this current funding does not necessarily meet the needs of all the adults that have prediabetes or diabetes in the US. And we'll hear more details about the scope of the prevalence of these conditions in the rest of the presentations today. So really today our presentations are focused on highlighting new opportunities, new partnerships, and different types of payment that can be established in order to support the ongoing implementation of these programs. And before I turn it over to the other speakers, I wanted to point out a few resources that we have available to support you in the work that you're doing in this area. First, we have the Best Practices Toolkit, Resources from the Field. This is a centralized location with over 200 resources developed by state and local community-based organizations around different aspects of implementing evidence-based programs, including information on strategic partnerships, evaluation, sustainability, marketing and recruitment, leadership and management. So chances are, if you're thinking about starting something new, or if you're looking for ideas, this is a great place to look for templates or examples of what others have done. We also have the Roadmap to Community Integrated Healthcare, which is an extensive toolkit of information about different types of healthcare organizations that you could consider partnering with for sustainability, as well as different types of payment and reimbursement that are available for community-based services. You could also consider signing up for our Center for Healthy Aging newsletter, where we provide updated information on evidence-based programs and other healthy aging topics monthly, and check out our information on social media as well as our other NCOA tools. If you have any questions or are looking for any specific resources, feel free to reach out to me, and I'm happy to find information that we have available as well as connect you to other organizations that are doing similar work. So without further delay, I am excited to introduce you to the speakers that we have in Virginia today. First, we'll hear from Michelle White, who is a program manager and epidemiologist at Health Quality Innovators. She is currently the task lead for 2 population health initiatives to reduce disparities in diabetes and cardiac health outcomes. Next, we'll hear from William Thornton, who has worked in the health and fitness industry for over 15 years, working in collegiate fitness for Indiana University, public health as the Indiana State Prostate Cancer Coordinator, and now with the YMCA of Greater Richmond as the Association Director of Community Health and Wellness. Then we'll hear from Kayla Craddock, who currently oversees diabetes and hypertension activities at the Virginia Department of Health as the Quality Improvement Supervisor. Kayla currently serves as the co-chair to the Professional Development Work Group of the National Association of Chronic Disease Directors Diabetes Coalition. Then we'll hear from Cora Plass, who provides consultation and support to the National Council on Aging's Roadmap to Community Integrated Healthcare. Prior to that, she was the Senior Director of the Chronic Disease Self-Management Education Resource Center here at NCOA. And before that, she was the Director of Healthy Aging at the South Carolina Department of Health and Environmental Control. And last but certainly not least, we'll hear from Joyce Nussbaum, who is the Health and Wellness Coordinator of Valley Program for Aging Services. She has worked there since 2010 and is a master trainer for the evidence-based chronic disease self-management program, as well as the versions specifically for diabetes, chronic pain, and cancer, originally developed at Stanford University. And she's also a master trainer for A Matter of Balance Through Maine Health and licensed to deliver the Aging Mastery Program and Fitness Drop. So without further delay, I'll turn it over to Michelle.
Thank you, Katie, for that awesome introduction to everyone, and thank you everyone else for having me here this afternoon to present to you. Okay, the next slide, please. First, I'm just going to tell you a little bit about Health Quality Innovators, or we call ourselves HQI. HQI is a private nonprofit healthcare consulting company. We've been a quality improvement organization, also known as a QIO, working under contract for the Center for Medicare and Medicaid Services, which you'll know as CMS, for over 30 years. CMS did some reorganizing in 2015, and since then we have become the Quality Innovation Network Quality Improvement Organization, or QINQIO for Virginia and Maryland. So I know exactly what you're thinking, so many acronyms. And we are also the practice transformation for Virginia, West Virginia, Maryland, and Washington, D.C. The Practice Transformation Network is also another CMS initiative. Next slide, please. So I'm guessing you're asking yourself, so what exactly is a Medicare Quality Improvement Organization? A lot of folks that I speak with out in my job, if I ask them, did you know Medicare had a Quality Improvement Organization? And generally that answer is no, I didn't know that. Everybody seems pretty surprised. Surprisingly enough, the QIO program is one of the largest federal programs dedicated to improving health quality for Medicare beneficiaries, and quality improvement organizations are actually required under specific sections of the Social Security Act. These organizations began operating back in 1972 as peer review organizations and were later renamed as quality improvement organizations in 2002. The QIO program's 14 Quality Innovation Network QIOs, or QINQIOs again, serve regions of 2 to 6 states each. So that's, I'm saying each state and territory has a QINQIO that serve them. QIOs bring Medicare beneficiaries, providers, and communities together in data-driven initiatives that increase patient safety, make communities healthier, better coordinate post-hospital care, improve clinical quality, and lower costs. These are sometimes referred to as the triple aim of better health, better care, and lower cost. And I know that it's a little early in the presentation, so no one's actually multitasking yet on this call, but just in case, if you are and you have a browser window open, just go ahead and Google QIO in my state and see if you can find your QIO. And if you really want to multitask, you can go ahead and just kind of type your QIO in the chat box once you figure out whom that is. Next slide, please. This slide kind of shows the different program areas in which QIOs are currently working. As you can see, we're going to focus on the diabetes program, which falls under the Better Health, or sometimes we call it the population health category. While every QIO might not do work in all of these different areas, for example, we do immunization work in one of our states, Maryland, but not so much in Virginia. Every QIO or every QIO does have a diabetes-focused initiative. Next slide, please. The Diabetes Initiative is known as Everyone with Diabetes Counts, or EDC. Yes, I know, it's again, one more acronym to remember. The EDC program is a disparities reduction program designed to improve health outcomes and quality of life among disparate and underserved Medicare populations. So as part of this contract work, all QIOs must engage providers to increase adherence to clinical standards of care. All QIOs also support self-management education in disadvantaged communities using an evidence-based DSMES curricula, and each QIO must develop and implement a sustainability plan for their DSMES program. Again, although these goals and objectives are the same for the EDC program for each QIO, how each one goes about this work is up to that particular QIO. So again, if you're multitasking and you actually find out which QIO serves your state, you can just kind of go ahead and Google the EDC program, and they should have that somewhere on their website. Next slide, please. So as I mentioned earlier, each QIO had to create a sustainability plan for their DSMES program, or the Everyone with Diabetes Counts initiative. The primary focus on sustainability is to implement or facilitate a train-the-trainer program. Sorry, that's very difficult for me to get out, for their chosen evidence-based curricula. Additionally, QuinnQAOs are required to support work that increases the numbers of certified diabetes educators, or CDEs, and accredited or recognized diabetes programs, and to facilitate the use of community health workers in diabetes self-management education and support. Again, all QuinnQAOs are supporting these goals, but may do so in very different ways. Next slide, please. So I'm just going to talk a little bit about how we went about this in Virginia. So for sustainability purposes, at the start of our contract in 2015, we chose to partner with the Virginia Department for Aging and Rehabilitative Services, also known as DARS, in order to support the 25 local area agencies on aging and to help them continue to offer their evidence-based chronic disease self-management education, or the CDSME programs that you kind of saw before in the slide that Katie presented earlier. Fortunately, the local area agencies on aging, which I'm going to refer to as AAAs from now on, because again, that's one of the other 3 words put together that is impossible for me to get out of my mouth most of the time. We're already using this diabetes self-management program, or DSMP, that was developed at Stanford University. You've probably heard it referred to as the Stanford model. And just in case you're not familiar with this model, this particular model consists of small group workshops that are led by 2 trained non-health professional leaders. The workshops meet weekly for weekly sessions. The sessions are between 2 and 2.5 hours apiece, and they last for 6 weeks. So participants get 15 hours of diabetes-related educational programming. The workshops are held out in the community settings, such as senior centers or churches, where it's easy for seniors to get to them and to participate in the workshops. Participants are encouraged to bring their friends, caregivers, or loved ones with them to the sessions. The sessions are very interactive, and everyone learns techniques to deal with things like the symptoms of diabetes, fatigue, pain, signs of hyper or hypoglycemia. Other sessions cover topics such as healthy eating, how to deal with stress, teach participants action planning, problem solving, and how to more effectively work with their healthcare providers. And most importantly, these workshops are free for the participants. So as Katie noted in her presentation earlier, funding for these evidence-based programs is limited and unreliable. And fortunately, thanks to some good timing, HQI was able to step in at the beginning of the contract and become the multi-site license holder for our states. Through this partnership, many AAAs that were either in danger of losing the ability to continue their CDSME programs were able to continue their programs and to actually even expand their reach. For example, several programs that started out only being able to offer the chronic disease self-management programs are now able to offer the diabetes self-management programs as well, and sometimes even more of the chronic disease self-management programs, such as chronic pain and cancer thriving and surviving. Additionally, especially in our state, there were several small local area agencies on aging in the more rural sections that in the beginning had no capacity to offer any of the self-management programs in their area, and today are actually able to offer 1 or more programs to their communities. I think I should also mention that while we hold the license, we still partner with DARS and help assess system with fidelity monitoring, and we also perform some of the routine license reporting requirements. So that takes that burden off of DARS and off of the local area agencies on aging. In addition to the 25 AAAs, there are also some additional nonprofit and other agencies that operate under our license to deliver these workshops. For example, in Virginia, we have community service boards, which are our public mental health facilities. One currently that operates under our license to hold DSMP workshops for their clients. HQI staff here, we have 4 master trainers and 2 lay leaders. So another way which we partner with DARS and the local area agencies on aging is to actually help them physically with leaders for their leader trainings and for their to provide their workshops. For some additional specific sustainability activities, in the past, HQI and DARS partnered to hold a master training session in 2016, which added about 20 master trainers to our state. And just for clarification, master trainers are able to train lay leaders to lead the workshops. Currently with DARS, we provide bi-monthly special topic calls on area of interest. These area of interest are chosen by the agencies themselves. We've covered topics such as participant recruitment and retention, lay leader recruitment and retention, and working with physician practices, just to name a few. HQI provides them with ongoing technical assistance and resources, which sometimes can be just as simple as helping a small AAA with their marketing materials to promote a workshop, or exhibiting at a community event and actually helping them to recruit workshop participants, excuse me. HQI also has an online dashboard of health literate diabetes and diabetes-related, cardiac-related patient education materials that local AAAs and other agencies can use to support their programs. Next slide, please. At a higher level, in order to promote sustainability, we utilize our state and local stakeholders and their activities to identify new opportunities for the local AAAs that are working under our license. Since the initiation of the contract, several federally qualified health centers located in both rural and urban areas of our states are now either hosting workshops for their patients or have had their staff actually trained as lay leaders and are continue to sustain the workshops there. Several primary care practices are also participating, and even a couple of specialist practices. I think we have 2 cardiology practices that are holding workshops for us on an ongoing and continual basis. We've supported a couple of local health districts to have their community health workers trained as lay leaders, and we've also been helping them implement a direct referral system from their community health worker network to their local AAA for their patients with diabetes. Another way we assist with sustainability is just here at HQI, utilizing our multiple resources across the different task areas that you kind of saw earlier. Our HQI pharmacist is a CDE. So by aligning with a medication safety task and collaborating with the Virginia Pharmacists Association, there are now pharmacies that are actually hosting and leading the workshops, which is very exciting. Some pharmacies are having their staff, like their pharmacy techs, trained as lay leaders to be able to continue to offer the workshops. We've also had some success working with schools of pharmacy as well. This year, 2 students took the leader training and became lay leaders and have successfully led a workshop in their senior low-income housing residents as part of their course requirements. And we hope to replicate this success in other parts of the state. These examples have focused mainly on the DSMES sustainability for the self-management workshops. We've used the same stakeholder alignment approach to increase the number of CDEs, accredited and recognized diabetes centers, and community health workers. For example, partnering with the Virginia Department of Health and the Virginia Diabetes Council, we've helped them establish a CDE mentoring program and be able to provide scholarships for diabetes education for health professionals and healthcare professionals alike. We've also worked with the Community Health Worker Advisory Group to design and implement a certification process. I'm not going to talk a lot about this now because you will hear more about these specific activities during a later presentation. Next slide, please. Anyway, I hope I haven't spoken too quickly. Here are some links to some of the resources that I've talked about. If you didn't get a chance to Google and find your QIO program and more about the EDC, the links will be here for you to find those later. There's also a link that will describe and take you to the DSMP workshops that we've chosen to use as our evidence-based curricula. So if you have any additional information or would like any additional information about any of these activities or any of the other ways that we've partnered with DARS and our other stakeholders, please feel free to contact me at any time. My information is on the next slide, please. And somebody's asking is who's paying the Living Well lay leaders? Is it volunteer or in kind? And generally speaking, most of the lay leaders are volunteer. I think a few agencies or entities may pay their trainers a stipend, but I think a majority of them use volunteers. And I can't actually remember as I was reading through this, because now we have a storm coming down in Virginia, and I'm kind of a little bit distracted about the noises going on, but these workshops are all provided free of charge to the participants, so there's no charge for anyone to participate in these workshops. So I think that wraps it up for me. I think I had one more slide for a Q&A, but I think we'll hold off for that till the rest of the presentation. So I will now turn it over to William.
Wonderful. Well, thank you. Thank you very much. Thank you to all my other co-presenters, and really appreciate the opportunity to be able to share, especially since this is such an important topic that we're trying to affect our community. Well, I'm with the YMCA of Greater Richmond, and wanted to share with you some of the things that we're looking at here and doing here in terms of sustainability, and really some of the fun lessons learned that we've had. If you go to the next slide. What I'm really going to share is based on our learnings related to our diabetes prevention program. We also have a diabetes management program. But for those who may not be aware, that the diabetes prevention program that YMCAs provide is a year-long program with 19 sessions that's delivered weekly. And then we move to bi-weekly sessions and then monthly sessions. It's done by lay individuals. Lifestyle coaches that are trained to deliver the program, and we do have a CDC-approved curriculum. And the goal, as we know, is to decrease a person's risk for developing type 2 diabetes. Across the country, we've served almost 60,000 individuals within the prevention program. We're in 46 different states across the country, and then have over 1,000 active YMCAs that are participating. Specifically here in Virginia, we have about 10 different localities that you can see in Virginia where we're delivering the program across the state, of which the YMCA of Greater Richmond is facilitating 3 different locations, obviously within our particular service area, but also in Emporia, and then we also are facilitating programming in Charlottesville as well. Next slide. One thing that I'll mention in terms of sustainability, an exciting thing that a lot of folks are aware of, is that the National YMCA Diabetes Program was part of a pilot study with Medicare and Medicaid, where the results were certified to be sustainable and effective at producing the results that we want, and cost effective for the Medicare population. And at this point, a lot of you know that that work led to where we now will have Medicare, Medicare coverage for our diabetes prevention program. Not only YMCAs, but others across the country. So a lot of folks are really preparing and applying to be Medicare suppliers in order to be able to provide that service. And when you talk about sustainability, being able to have something like that across the country covered as a covered benefit for a very needed population speaks to how do you have sustainability. And a lot of the work that I'm going to speak about is really about partnerships, and that is what's really been able to sustain us in terms of programming. Now, of course, you do have to have great results, and a lot of folks have spoken to the fact of funding is always a question. So whether you are a person on the call that's for-profit or not-for-profit, figuring out what is that mix of payers that you might have. We have a mix, whether that's direct payers, people paying directly as individuals, organizations or health systems paying for folks, and then, of course, grant funding. And figuring out what's that mix that will keep you sustainable is also a true key factor. Next slide. But for us, really the clinic to community linkages is what has really allowed us to keep going, keep getting people into the programs and really being able to serve the community that we have. And so that's one of the areas that I'll focus on, and a lot of the lessons learned that we've had over the years in delivering diabetes programs. And next slide. So for us, one of the things we looked at initially in creating these linkages is one of the tools that CDC provides in terms of clinic to community linkages, and at the bottom is a resource that you'd be able to refer to. If you go ahead and click through, that should advance each one of those and go ahead and put each one up. But the first step in creating those linkages is really learning about the community that you're trying to serve, and what are the issues that they are facing or barriers to being able to get these services, and then really identifying those partners that are within the community that you can connect with, that you can add value to in terms of working with them in partnership in order to deliver the program in a variety of different ways. When we talk about identifying partners, it's not only partners that could possibly refer in, but they can also help facilitate the delivery of the program and any additional services that are needed. The YMCA, one big thing that we're able to offer is additional opportunities to be physically active, but you could partner with other organizations that could add that or have that as a component that could add value. We also partner with pharmacists as well. We also partner with dietitians as well to refer people to any additional services that they have, and that also becomes a reciprocal type of agreement. The next thing is really, as you're preparing these linkages, is having agreed upon goals and objectives. Who's providing what? How is that going to work? What is it that we're looking to accomplish in kind of this linkage? And when I do get to the next slide, that'll come together more as you build out these referral networks that really sustain you getting people into the program, and also building a network of people that can tell others about the program. This next one, the K, or know which operational structure to implement. As you work with different partners throughout your work, how is it actually going to work? If you are going to have a referral system, what is the business process that's going to work in order to get a referral from point A to point B in order to be able to connect them and then connect them to the program? That has been a huge learning for us in that each business or partner is obviously very different, and how we work with them and having flexibility in order to move forward, in order to get people into your program. I would say right now we have about 70 different partners that we do work with at various levels in order to refer into our program, or providing some type of support in terms of getting the word out in the community, or supporting the program financially through grants, or supporting the program as an employer group, providing this as a service for their constituents. The next one, aim. You do want to aim to coordinate and manage the linkage. It's definitely not a set it and forget it. It is a lot of relationships that you do have to build in order to get the results that you want, which is folks consistently coming into the program, because we find that there is a lot of work that has to occur in order to get a person that obviously qualifies for either if you have a diabetes prevention or management program, and getting them to that first class and working together to really get them there. Grow the linkage with sustainability in mind, looking at how do you continue to have shared goals, and really evaluating and really giving feedback. This was what we used initially in order to really connect in the community, in order to consistently get people over the past 4.5 years into our program, being able to serve, well, just in our service area in Richmond, well over 1,000 people within the program that would successfully complete. We probably have somewhere near a little over 2,000 individuals that are referred into the program, and then getting people to participate is always what we work towards. If you go to the next slide, one of the things in terms of engagement that we found, we get referrals into the program from a variety of sources, whether that be going out to community fairs, community events. We go to work sites. Obviously, we work with providers, our YMCAs. In our service area, we have 16 locations. All have members that we try to recruit into our diabetes programs. And what we found is, out of all those different referral sources, in order to get people in, working with the clinical providers has provided the best yield in terms of taking a person who is eligible and them actually enrolling and showing up on day one. So when you talk about sustainability and resources, focusing on referral sources that can yield the best results is key. And one of the things when you look at number one here is in our engagement mapping is looking at background information. And a lesson learned that we had is obviously we have folks that deliver the program, folks that oversee the program, but really within your organization determining who will be that person each day that looks at establishing the relationships needed in order to consistently get people. That's whether you're a community organization and you're still trying to get people to come into the program, or you're already within a hospital system and you still need the providers to actually send and refer people into the program so that you have people. It's all about those relationships, and having a designated person to really drive that was a key piece beyond just the delivery of the program in order to really get people started. But one of the key things is really identifying the providers. We do have a community advisory board. If you go back forward one more, we do have a community advisory board that we've established of folks within the community that helps us to identify providers that might be able to refer into the program. And then we leverage a lot of the warm resources that we have with our different boards. And then part of my role is to go out in the community and build those relationships with different provider groups as a whole and identify who that might be. The next step is really planning to engage those providers and really looking at what is the connection that you might have with them. Is that particular group, if it's an employer group, is diabetes a number one claim that they might have, and that's how you can connect to get referrals. Is there that hospital system? Is it a patient in a medical home, or is there a high Medicare population? What is the connection that you might be able to have to fulfill a gap? Has there been a community health needs assessment that has identified some of these needs so that you can help work to fulfill a gap? These are the pieces of information that you would put together and then kind of prioritize that list of different things and see, well, what would be the number one reason why this provider would work with you and send folks into your program. The other approach that we've had with planning and engaging providers is looking at larger groups, so not going one-to-one in terms of physician practices, but looking at either medical societies, larger social organizations. We have been successful in engaging, and we have a statewide partnership directly with Walmart, where every Walmart pharmacy in Virginia does refer into the diabetes prevention program. And so looking at what different connections that you can have will allow you to be sustainable a lot better in terms of connecting with folks that have constant people coming into the program that can help really sustain you. The next one is really engaging and pitching to providers. And so when you look at that, really making sure that you do have a connection with them and you discuss really what is that referral process going to look like, how's that workflow going to happen, really letting people know about the research related to the program so that they can be engaged and want to know that their patients will be successful and going into a successful program. Once you have that group or different providers on board, really formalizing the partnership is a good way to go in terms of some type of actual agreement. We do have formal agreements with several different organizations in terms of who's providing what, whether it is a service, whether it is direct referrals, in terms of that particular partnership, in order to create sustainability, and so that after you've done all the work to identify people, you've created a workflow so that people can be referred in or a service can be provided that will enhance your program. You do have something formalized in order to sustain that, to be able to bring that back, so year over year you can continue to be relevant and using those folks. And then the last step of what we look at in kind of this engagement and building these partnerships is really looking at the referral and implementation and making sure that as we look at those pieces, we really are thinking about the actions that will really maintain success for that particular referral and continue to cultivate the relationship. We've developed several different tools that allow us to do that, whether that be in terms of point of care, where we have things like a prescription pad that allows people to refer directly into the program or to the YMCA. We have marketing materials that we put up in physician offices, employer groups, in order to continue and implement the program. We work directly with a lot of those providers in order to, whether it's a retrospective query of their health system, in order to send out letters to individuals. We work with them to have any type of point of care prompt in their electronic medical records. And then we do track the referrals and provide a feedback loop that I'll talk a little bit more about as a whole. And the combination of those things really formalize the partnership and allows folks to continually to refer. And if you notice here that it is a circular process where you're constantly going back, we find as we've had providers for multiple years, that's the challenge, to continue to keep those providers and those partners engaged year over year in order to continue to send people. Next slide. So one other huge thing that is a lesson learned for us in terms of referral networks is really having a flexible system. We do offer 3 different ways that people can refer depending on their business workflow or process. One is some type of paper referral that we use in all of our locations. We use it at health fairs. Providers can send that through a secure fax or secure email when it is a provider. And so that's one way that folks can get into the program. The other one is working with electronic referrals. So we do work with electronic medical records. We do have electronic medical record system ourselves through AthenaNet. And then we do work with other providers to integrate with them in order to move that forward. Definitely not an easy task in order to do that. We do have one that we have just solidified in order to move forward, but it is a great way in order to make it easy for providers to refer into the program. The last one is we also have a website portal that allows for self-referrals or for other providers to be able to refer into the program. And I think over time, we initially only had one of these options, and that has definitely increased our ability to meet different organizations' needs and where they are in order to continue to be sustainable and have people coming into the program. Last 2 slides. Go to the next one. So, and as a takeaway, I'm sure a lot of you have seen this particular side and the iceberg, and really diabetes is what we see on top, this idea of diabetes prevention or pre-diabetes, with 86 million Americans being pre-diabetic, and a good majority of those folks not even knowing is what's below the surface. And with 37% of the adult population being affected by this, we definitely don't see that we can do it alone. And so if there's one takeaway for sustainability, is finding ways to partner with other folks is the key. Next slide. And so opportunities increase when you help others to win. A little win for a partner is a little win for you. And so the more you can partner, the more sustainable you'll be, whether that's through funding, getting people referred in. And then the last slide is really one of the biggest lessons learned that we have is really this feedback loop. Everyone that we talk to, whether it's a funder, a provider, really wants a feedback loop in terms of how things are going. So what we've developed with all of our different partners is, one, we do a feedback at week 8 and week 16. And we also do an aggregate feedback to anybody who's referring to let them know how many people have been referred, how many people have come into the program as a whole. And then now we've developed where we will start providing feedback for each individual provider at week 8 and week 16 in our program in order to let folks know, one, those folks their needs are being met, what the outcomes of those are, and then how are we really impacting the community as a whole. And I think that those two, the partnerships and feedback loops, are the big pieces that really create sustainability and keep people being referred into the program. And the last slide shows just my contact information. If you do have any questions, I'll be happy to answer that. I think in the chat, I think we'll have some question and answers, or if you want to follow up with me at another time. I think there was one. Are we answering any questions now from the chat?
William, this is Jen. I was going to save them for the end, just because
Okay.
of time, but yeah, if we could just kind of move forward, and I am monitoring them. I see your questions.
Okay, so I'll wait. I won't respond in the chat.
Great, and now we'll turn it over to Kayla from the Virginia Department of Health.
Hi, good afternoon. Yeah, Michelle's right. We're having some crazy weather here in Virginia, so I apologize for any noise you might hear. But I am going to talk with you all today about what have we done here as a department to look at statewide diabetes activities, and how do we influence those activities from where we sit, and then how do we bring partners together that really have the impact, such as Michelle and William have described. So with that, you can go to the next slide. So our mission at the department is to protect the health and promote the well-being of all people in Virginia. I think that's a pretty good mission. Happy to work for an organization that seeks to achieve that. Our vision is to become the healthiest state of the nation. So I always like to provide just a framework for the department. So what do we look like? How are we organized? Because that really impacts how we do our work and how we do it well, and how do we engage our partners. So the map you have there identifies the 35 health districts. So we are centralized in that I sit in Richmond, Virginia, which is the capital, and we have our state office, and then we have the 35 health districts that work in their cities and counties. So within one district, if you can see there, that West Piedmont, down kind of on the lower left-hand side, that's what's considered Southwest Virginia. That actually has 3 individual offices within that one district. So depending on where you're at, you could have multiple offices within one district. So to look at this map and step back is to say that we already, just as an agency, have 35 partners, because each of these districts, they work with their own city, county planning, partners and staff to facilitate activities in their localities. And as a department, we oversee many things, not just chronic disease. So all of our water, any kind of WIC activities and things like that come out of those local offices, and then our office supports them. The next slide. And the next thing I like to look at is data. So we are a very data-driven agency, because without data, we don't necessarily know if we're improving, getting better, getting worse. And so I've provided some maps here, and I know the colors may not be the easiest to see, so I'm going to talk with you through those. So as an agency, we do collect a lot of data. Do I directly collect it? No. Is it collected by other partners in our office? Yes. Is it analyzed by people with a skill set higher than mine? Yes. So we work very closely with our epi and evaluation team. So this map right here is age-adjusted diagnosed diabetes incidence rates in Virginia. So this actually, the data came from CDC. So we want to look at where is the diabetes occurring in this state. And so the darkest gray is where we have the most incidence. So it's where we have the highest diabetes rates happening. Next slide. And then here's another slide, diabetes burden. And so this map actually is using data that's collected from the Behavior Risk Factor Surveillance Survey. So if you're not familiar with some of these data sets I'm talking about, feel free to throw your question in there. But the BRFSS, that's a tool that every state uses, and CDC supports states in the analysis of that data as well. It is a survey, so it's people taking phone calls, and that data gets reported back, and it's adjusted to be representative of the whole state. So here you will see, again, the darker color is the highest burden. So if you looked at the survey tool, the question is, have you ever been told you have diabetes? So that's how this data is collected and what's reported out. So most of our data, we do report it at a district level. We can go down to the county and the zip level, and that's important to speak to, like Michelle and William's earlier slides and conversations. We need to know who those partners are in this community so that we can affect that burden and reduce that burden. The next slide. Hospitalization. So this, we have a lot of colors on here, but red is your is the worst color. So this doesn't follow the same color patterns as the other maps, but this is data that's collected through our called Virginia Health Information. So they collect all the hospitalization data and they analyze it, and that's how we know what's happening in our larger healthcare systems in the state. So this is data collected in 2015. Often we look at data a little behind real time just because of the nature of the analysis that needs to happen. So red on this map is the largest inpatient hospitalizations that occur because of diabetes. So this is going to be someone who's come into the hospital and diabetes was the primary cause for that hospitalization. And there's a lot that we've done to look at how do hospitals collect and code that data. What does that mean when you look at chronic diseases? Because often when we go to the hospital, well, I hope no one on the call has had to go to the hospital often, but often they're collecting so much data. So how are they tracking and monitoring it? And often what takes us to our primary care or hospital, it's not often the root cause. So the data here for hospitalization is important because it tells a story as to what's happening to bring that person into the hospital and then what happens once they leave. Next slide. And then this is my final map to show you all. We have a tool here in Virginia. It's called the Health Opportunity Index. And so what that Opportunity Index does, this is a tool that was created and it's supported by our Office of Health Equity. We really want to know if you live in Northern Virginia, what is the likelihood of you achieving health? So what's the likelihood of you being a healthy person and making healthy choices versus that of someone who's living in Southwest or even the central part of the state? So I do not analyze or work on this tool directly. So I'll just explain what do the colors mean and what does it mean to have a high health opportunity. So high health opportunity is actually the darker blue. And so what that means is I have more access to either healthcare provider offices and systems. Maybe I have more access to food, so it's not a food desert. There's a lot of grocery store options for me. I have access to good water systems and things like that. And then when you see the colors get, I guess the greens and the yellows, that's when you don't have as much opportunity. So you see in our Southwest part of the state, we don't have a lot of healthcare options there. So that significantly reduces someone's opportunity to get treatment and care that they may need to manage a chronic condition. So just a couple different data options for you guys to see how how you can work with your state office to give you some real-time data on something that's related directly to your program, or maybe data that would support you seeking other opportunities or activities beyond what you're currently doing. So I always encourage folks to connect with your state offices when you can. The next slide. I pulled out some more data, as did William, just looking at what is our burden here in the state. So over 2 million Virginians, 1 in 4 adults has prediabetes, but often people don't know that they have it. 15 to 30% of those people will develop type 2 diabetes within 5 years. Over 600,000 Virginians have diabetes, so that's about 1 out of 11 people. And then around $245 billion is what's spent because of or lost wages. So when you have to call out of work because you've got to go to appointments, or maybe you've had to be hospitalized because of an adverse event related to your diabetes management. So these are the stats and the things we look at as to why it is so important to work together and partner with folks. So the next slide. So how are we working on this? Prior to my joining the department, we were structured a little bit differently, and that was just based on how our funding and programs were aligned at the time. But they were able to work with different partners, so state agency folks, as well as community partners, to develop our Virginia Diabetes Plan. And it was a great plan because we didn't have anything like that in place prior to that being developed. But then we didn't necessarily revisit that, and we didn't necessarily convene folks in a way that would make sure the things outlined in that plan would happen. So that's something as a lesson learned. You know, you can develop a plan, and that's great, but you actually have to do the plan to see some outcomes. The next 2 bullets are bullets that highlight funding that we receive from the Centers for Disease Control. Every state received the first bullet there, state public health actions to prevent and control diabetes, heart disease, obesity, and associated risk factors and promote school health. So it's quite a mouthful, and I know I said that fast. But in short, that grant was a collaborative grant for our chronic disease activity. So I sat beside our obesity coordinator, who was working with schools and early child care centers. And I'm working over here with adults on diabetes and heart disease activities. So together, this grant had a more collaborative and impactful approach, because we were already writing together to say, okay, if you're focused here on this, I'm going to come up behind you or alongside you and also bring in these other resources to have maximum impact. So third bullet there, state and local public health actions to prevent obesity and diabetes and heart disease and stroke. That was a grant that was not awarded to all states, but awarded to about 14 states, I believe it was. So that took the state work and it localized it. So here in Virginia, we localized and operationalized that in those local health district offices that I mentioned earlier. So we had 5 health regions, and we picked 1 district from each of the regions so that we could represent the entire state. So what we did at the state level, they mirrored at the local level. So they really took that engagement to another level and looked at the partnerships and what are the things that need to happen on the ground to make all this work. Our Virginia Diabetes Council, they were a part of that Virginia Diabetes Plan I mentioned earlier, but they didn't necessarily, they weren't maybe at capacity prior to us re-engaging them through our grant work. So we have felt that bringing them back on and into the fold has been critical to do our work, because we only have so many staff at my office, whereas the council has everyone in the state who's working on diabetes or has some kind of interest in diabetes. So that could be your school nurses. It could be your pharmacy people who also have educational resources and tools. It could be your healthcare providers who have an interest. We have had podiatrists. Foot care is very important in diabetes. So anyone working on diabetes, we've recruited and try to push them towards joining the Diabetes Council. The last bullet there that I will mention is the development of our Preventing Diabetes in Virginia strategic plan. So through our funding, we were tasked with looking at what are we doing to prevent diabetes. It's a huge burden, and what are the steps and actions we're taking to get to prevention. So not just talking about prevention, but again, what are the steps and the things that we're doing. So we brought together different Virginia partners, one of those being the Virginia Center for Diabetes Prevention and Education. That's actually housed out of the University of Virginia. We brought them together to help us do some formative research to say what is going on in the state, who is offering diabetes education, be it pre-diabetes, prevention, or diabetes management. So they helped us facilitate this research behind the strategic plan. And then in the fall of 2016, we brought together over 100 state partners to actually have a working meeting to put that plan into writing. And from that 2016 point, we have actually put that into practice through some work group development and focused attention. So it wasn't a plan that was sitting on the shelf. Next slide. So to get a little more specific, I've talked a little bit about our grants and like who our partners are and why it's so important to do that. But what can you do once you bring those people to the table? So again, grateful to be on the call today because of all the work that I'm supported in by the folks that are on these calls. So educate. We need to educate people who have diabetes or who could potentially get diabetes on their risk and on their resources that could help them. We also need to educate our providers because providers have a lot to do. I've seen some comments through the chat and all about EMRs and all of that, and like who's paying for all of this and things. The providers have a lot on their plate, so we need to make sure we're educating the providers too on the resources that are beyond their walls if they can't take it on themselves. Increase access to programs. So work sites, people are at work most of the time 8 hours a day. So that's a big chunk of the day. Why not build out some healthy activities and opportunities in that space? Community-based, our YMCA programs, our the Stanford programs that Michelle mentioned, the EDC work that they've done. Just what's going on that someone in the community could access to better support healthy activities. Training individuals and leaders in the field, so community health workers, they're critical members of our communities. They've been called different things, so resource mothers, lay health educators, promotoras, could go by several different names, but they are people who are from your communities and who are working to support people who don't necessarily know how to navigate a healthcare system. So we've really put a lot of work and energy in our community health worker advisory group and association to support training and core competencies that make sure our CHWs are trained and can be effective in their communities. Lifestyle coaches, that's a term that's really paired with the diabetes prevention program, so making sure they're adequately trained and they are able to support individuals that are going through those programs. And then how do we communicate across program areas? So it's one thing for me to say, oh, this stuff is happening, it's great, I think it's lovely and wonderful, but I need William and Michelle to show up to those things. I need a provider to pay attention. So how do we communicate effectively? Next slide, please. So these are a few of the examples of some of those communication resources and tools, and a lot of this stuff is actually available to folks on this call. So we have those infographics there. Those were originally developed by CDC, and then we adjusted them using Virginia data. So if you just do a quick Google search, you can find a lot of different data and infographic resources that are appealing, and they tell a great story and they're impactful. So we've used those a lot. We have branding here at our agency, VDH Live Well. So that's something that we've tried to push to promote, again, those healthy living activities that are related, not just, to chronic disease, but, you need to eat fresh fruits and vegetables. And that encompasses everything from, birth to getting older. So Live Well is a great message we've been able to push out here. Prevent Diabetes Stat, that's the national tool and resource that is used to educate your providers. And then So Do I Have Prediabetes? That's also a national resource for folks. By folks, I mean individuals and the public who, get tested for prediabetes. So they can use a quick 9-question survey to determine their risk for prediabetes. Next slide, please. So this is a slide to just highlight some of the specific marketing we've done around the diabetes prevention program. So we partnered with CDC and the National Association of Chronic Disease Directors and CBS to do some really cool marketing that without their support we wouldn't have been able to do. So in October through December this year, we were able to support pre-diabetes messages that aired on those waiting room TVs. So when you go to the doctor, and often we don't want to be in the doctor's office, so you're sitting there and there's the TV. Those TVs are often monitored and supported by different health message groups that come in. So we were able to push out that pre-diabetes message through that. In May and June, we this year are going to support increased awareness around the Medicare diabetes prevention benefit. So letting people know that this is a new benefit that they can access, and making sure that providers are also aware of what's going on with that. And CBS Health Watch is, we're also going to do some more messages around that. So those are available videos that CBS's health team put together that it's great. We couldn't have come up with anything better than ourselves to do. So happy to have those resources. And when you look at communication and marketing, impressions is often how many times is something clicked on or looked at, and that's how you would measure those. Next slide, please. I apologize, I did have one more map. So this map we created early on in our grant work to show where are some of our diabetes management programs and diabetes prevention programs as they relate to where our federally qualified health centers are located and where some of our funded districts are located, so that we could see where are we putting our efforts and time and energy, and how can we maximize the work that's happening, and then where are those areas that have some gaps. So mapping is a great tool. Sometimes you can put a lot on the map like this one, but if you're able to just step back and think about, well, what do I want to see and what do I want to know, you can overlay some things so you can see where you do have gaps and where you might need to go in and provide some more support. So when this map was created, we didn't have as many of the red triangles, which represent our prevention programs, but since this was developed, we've increased drastically. So that would be an update I would want to make to this. And the way those districts are highlighted, I might want to remove that because some of that is going to be adjusted just based on where we're at with different funding activities and things like that. Next slide. And then just a final slide to talk a little bit more about the State Diabetes Council. So if you are in your state and you're like, I don't know if we have a council or coalition, I guarantee you if you Google it real quick, you're going to find some information. So ours is called the Virginia Diabetes Council. We have a prevention work group, a self-management work group, a school health work group, and then there's an advocacy group. Advocacy is critical, it's huge, because often folks and people who are working at that level in your state, they may not know all the information, so it's important for you as experts to provide information and resources. So working through your coalitions and councils, it gives you more resources for your day-to-day, or it just gives you more opportunity to be involved. So I would encourage you to do that. They have done some marketing, which is the image of the lady there. That was done on Facebook. And then the mapping there was also done as a way to show where are those groups and programs located. And then next slide. Feel free to contact me directly if you have questions about what we've done here at the department or what we've done through our council.
Thank you so much, Kayla. And now we'll turn it over to Cora Pless.
Good afternoon, everyone, and thank you, Katie, for inviting me to be part of the webinar today. I'm going to talk about Medicare Part B services to support people with diabetes and coexisting conditions. Next slide, Katie. Okay, so I wanted to begin with a few quick facts. multimorbidity or multiple chronic conditions is a serious, costly, and growing public health problem. 1 out of 4 adults has multiple chronic conditions, and the prevalence increases with age. 2 out of 3 adults age 65 and older have multiple chronic conditions. So you can see this is a very serious problem. And most adults with diabetes have at least one coexisting chronic condition. Conditions that commonly occur with diabetes are hypertension, high cholesterol, cardiovascular disease, obesity, chronic kidney disease, arthritis, sleep disorders, depression, etc. So you can see this is a huge problem. And 40% of people with diabetes have 3 or more chronic conditions. So this data is compelling and calls to us to provide a broad-based and holistic approach to treating and managing diabetes. Ignoring multiple chronic conditions can lead to ineffective control of diabetes and also missed opportunities to improve health outcomes for those who are living with diabetes. Next slide. So multiple chronic conditions increases complexity in managing diseases. This is pretty much common sense. We all know this. Some of this is related to the difficulty in coordinating care among multiple providers, but there are other factors besides that. And also there's an increased risk of poor patient outcomes. We know that individuals who have multiple chronic conditions have more symptoms. They may have greater difficulties just living a healthy lifestyle because of those symptoms. They are more likely to have functional limitations, develop early disability, and even premature death. So multiple chronic conditions have skyrocketed our healthcare costs and placed in place a tremendous burden on our health and welfare systems. For these reasons, self-management and treatment strategies need to incorporate an understanding of the combined effects of these conditions on a person's health and overall well-being. Next slide, please. So what I'd like to do is tell you about some Part B Medicare services that can help to take this broad-based approach. First of all, though, I wanted to talk about those benefits that are specific to diabetes. And the first one you all may be familiar with is medical nutrition therapy. This is a benefit that provides nutritional assessment and counseling on a group and individual basis for persons with diabetes, chronic kidney disease, or those who had a kidney transplant. And the diabetes self-management training benefit provides outpatient education and training services and those services must be accredited by the American Diabetes Association or the American Association of Diabetes Educators. The Diabetes Self-Management Program, or DSMP, that was originally developed at Stanford can be offered as a component of DSMT. It can actually be used as the curriculum for a nationally accredited program when the appropriate clinical supervision is added, and there are also some other, what we call wraparound components that must be provided. The roadmap that Katie mentioned earlier has a lot of resources that will tell you how you can provide DSMT to sustain the DSMP Stanford model program. And also I wanted to mention that ACL has developed an excellent comprehensive toolkit that guides you through what you need to do. So if you go to that roadmap, ACL's toolkit is there, as well as multiple other resources on nutrition therapy and DSMT. Next slide, please. And now as we think about a holistic approach, broad-based, so that we are taking into consideration these other coexisting conditions, I wanted to talk about 2 other benefits. Probably most of you are familiar with the new Medicare benefit, chronic care management. And this benefit provides care coordination and care management for individuals with multiple chronic conditions. And that's those who have 2 or more chronic conditions. And this CCM benefit provides a great opportunity for community-based organizations to promote your services and work with healthcare providers to offer this coordination of care and care management. There are just unlimited opportunities to do this, and you can also incorporate the evidence-based programs as part of the chronic care management. These services don't have to be provided within the doctor's office. They can be on the phone, in the community, or even in a person's home. Another service that most people don't even know about and is very underutilized is a service called Health and Behavior Assessment and Intervention. This sounds like a behavioral health service, but it's actually a psychosocial service to address the social, emotional, behavioral, or cognitive barriers that may interfere with management of 1 or more physical health conditions. So it's really looking at the linkage between the psychosocial and physical health. And it's really a great benefit that offers a lot of opportunity to help people better manage their conditions. Clinical supervision has to be provided as defined by Medicare with all of these benefits. But when you provide the clinical supervision and the appropriate wraparound structure as defined by Medicare for each benefit, CDSME programs can be included as a component of Part B services. So again, these are untapped services. They're not utilized to the extent that they could be. And I think there's just great opportunity for community-based organizations to use these programs these services to develop integrated and sustainable service systems for their CDSME programs. And Joyce is going to be talking about her experience offering the HABI service.
Okay, thank you. So I am the Health and Wellness Coordinator for Valley Program for Aging Services, and you can go ahead and go to the next slide. I'm just going to talk really briefly about the opportunity we had to partner with the Jefferson Area Board for Aging to offer chronic disease self-management as part of an HBAI service at a senior center. When I was part of a cohort that Cora led to help us understand this program, I kept running into the barrier of people saying, has it been done before? Have you billed for it before? Who can prove to us that this works? And so JABA had a nurse practitioner who could provide clinical oversight for us. And short story is that we were able to successfully bill Medicare for the nurse practitioner's time using E&M codes for these services that we provided for folks with chronic disease self-management program as the intervention. Next slide. So along the way, we learned some lessons, and I didn't have room for them all on one slide, but I can tell you that the best partner, probably for anything, but specifically for this, is enthusiastic about CDSME in this case, and also can provide services that complement your program. The reason I say that is because we're really well situated to offer the intervention, but didn't really have the capacity to do any billing, and didn't know a whole lot about the billing process. And so one of the lessons that I learned is to find somebody who has those skills and knows more about it than I do. I would also suggest, if you try this, to use a session 0 or something, a pre-workshop session, to develop the educational plan. So once patients or individuals are referred by a physician or somebody to this program, you can use a session 0 to let them know what chronic disease self-management is, and they can decide then if it fits into their objectives for improving their health, and then the educational plan can be developed at that time. I say be patient and tenacious because it took us a really, really long time to get it figured out. And there were some barriers that I don't need to go into that were probably specific to JABA, but it doesn't always work out fast, but it did work out. We were able to actually receive reimbursement for some of the time that the nurse practitioner spent using those codes. Next slide, please. So why is this even important? Program sustainability is one reason, and not just the financial piece, but also the fact that having a healthcare provider partner with a program like this can make it a little bit more relevant, and can also reinforce what is taught in the workshop, and can also sort of validate what is taught. Another really valuable thing is that participants in the workshop can ask the clinician, the supervising clinician, questions that leaders really can't address during the workshop. Where leaders are trained to say, that's a question for your healthcare provider. We're not really qualified to answer that. And sometimes folks forget until their next appointment. They don't even ask the question, or they're frustrated because they really want to know sooner rather than later because they're interested in making the improvement now. So in this case, the clinician could be available after each workshop session or between sessions for the folks that were participating in the workshop to ask their specific questions. And I think it also just enables participants to receive a much more comprehensive intervention. Chronic disease self-management workshops are excellent on their own, but when they're wrapped with time with a healthcare professional before and after and then during, it just really adds value to the program, and it helps, I think it helps participants take it a lot more seriously. So that's really all I have, unless you have questions for me later.
Thank you, Joyce.
You're welcome.
Thank you. This is Jen Cooper from APHN, and I just wanted to see if we could make sure we get to as many questions as we could. And thanks to William, because I saw William answering some in the chat box. So I will just kind of circle back here to see what we can answer. Liz Harrison had a question. I believe this is for William. Could you talk more about the process for establishing the partnership with Walmart pharmacies for program referral?
Sure. So that partnership actually stemmed out of, believe it or not, a couple years of work with Walmart in our Greater Richmond YMCAs. And initially that had actually nothing to do directly with referrals. But because we had built the relationship where Walmart was coming into our YMCAs providing flu shots, immunizations, vision screening services. Were doing glucose screening as well. We were able to show impact that we were having kind of in our area, and wanted to expand that partnership. Because we did have a partnership, one of the things that we looked to leverage was referrals into the diabetes programs if we were going to expand that wider. And so as part of that expansion with the agreement to be more statewide, that was one of the requirements that we wanted to have, is a referral system for the diabetes program. And we were able to work that out into it. And so the partnership is not only diabetes referrals, but we have agreement across the state of so many touches where Walmart is in the YMCAs providing these different vision screening, glucose screenings, those types of things, and then a certain number of locations, times where the Y is actually in Walmart, talking about programs and services as part of the partnership.
Great. Sounds like a great partnership. Thank you for that, William. There's also a question from Christy King asking, are they billing for DPP services? And I assume I think that came up when William was talking as well. And William, you had answered some other questions about funding and reimbursement, so maybe you could speak to that.
Sure. So in terms of that, we have basically three mix of how the program is funded. One, obviously, is grants, like everybody knows and loves. Then we do have individuals, like an individual person would pay to participate in the program. And then we do have providers, meaning that could be a company, a for-profit company, and we're providing it for their employees, and then they'll pay for it. It could be an insurance company, and then they are paying for it. And then at this point, we are getting into billing insurance. We do have a couple pockets where we have done that, particularly with United Healthcare in the past, and then we will do that on large scale as the Medicare project rolls out and being able to bill Medicare for it.
Great, thank you. Thank you. And I know I saw a question earlier and I don't see it now, but I want to make sure I ask it. Jasmine asked if every QIO has a falls prevention initiative as well. And I believe that was asked when Michelle was presenting. So Michelle, are you able to address that question? Michelle, I don't know if maybe you're not with us anymore, or you're on mute, but I can, we can get that question answered and get back to you, Jasmine. I know you had asked that earlier. Oh, Michelle?
Oh, can you hear me now?
Yes.
Okay, I'm sorry.
That's okay.
I unmuted the phone but didn't unmute the computer. Apparently, if you mute a Zoom, you have to do both. I know that many QIOs do fall prevention activities under the care transitions task and their patient safety task, but it is not a specific task area like the EDC. It's just encompassed in some of their other work, if that's helpful.
Okay, thank you for answering that. And we did have a few folks type in there what they found as far as their Quinn QIO in their state. So thanks for Paige. Paige, I don't know where you're from, but you typed in Qualis. And then Patricia also typed in her Mississippi QIO, which is adamalliance.org. So Michelle had mentioned that you can Google QIO in my state and you can find your QIO that way. So thank you for that, Michelle. And I think the other questions we had on here, William had already answered basically about fees and reimbursement for DPP. So we're almost here at the end of our time. So I just wonder if anyone else had questions that you want to include either in our chat. I see one just came through in our chat, so I'm going to go down. Is there any insurance reimbursement for the Living Well programs? Is a question that just came in. Joyce, I don't know if you were trying to answer.
Yeah, I can try to address that.
Go ahead, sure.
We have just recently contracted with Virginia Premier as a state to provide workshops for their customers. Haven't gotten any referrals yet. It's just very, very recent. But other than that, I am not aware, besides what Cora shared about, ways to bill Medicare and possibly Medicaid for some of these things, I'm not aware of any other partnership with an actual insurance provider.
Okay.
This is Cora, and I just wanted to add that many private insurance plans do cover the DSMT benefit, and they may also cover some of these other benefits, so you need to inquire because there may be opportunities to provide the benefits more broadly than just with Medicare. A lot of times when Medicare starts offering something, then the other insurances tend to offer it as well.
Thanks, Cora.
And some state Medicaid plans too. I just wanted to add, as Joyce already mentioned.
Okay. I want to also ask a question for Michelle from Marjorie, who's asking how are participants referred and what is the retention rate for participants?
We get participants referred from just a variety of mechanisms. We have providers that refer participants, pharmacists that refer participants. The AAAs will go out and distribute flyers and whatnot to to get participants from the communities. Faith-based organizations will host the workshops for their participants. We often find them successful to go to senior living residences and where the residents live and provide the workshops there. I know AAAs and entities that advertise in newspapers and just other media forms. I've seen them advertised on Facebook and social media outlets. So I don't think there is, any one way. It is definitely work to recruit participants. Mm-hmm. Mm-hmm. And I don't have any specific numbers on retention. In order for them to be a successful completer for our purposes, the participant must attend 4 out of the 6 workshop sessions. And just by looking at all the paperwork that comes in from across the state, I would guess that only between maybe 20 and 30% of classes have enrollees that complete all 4 out of 6 sessions.
Okay, thank you. Thanks for that, Michelle. We are actually a little over time, so I want to just mention that most of the presenters have their contact information in their slides, which will be posted along with the webinar recording on the APHN website, which is phnurse.org, and I'm sure that the Midwestern Public Health Training Center will have it on their site as well if you're in that region and part of that network. But I want to thank all of our presenters today and NCOA for being here, and also for the Midwestern Public Health Training Center for hosting. So thank you all.